That was one of my questions. Where with this, I mean, you're going in.
You're going in.
You're going in here.
Is it possible to be in suspended animations for decades and decades?
Right.
He's pursuing this. They weren't original ideas of his.
No.
Yeah, venture hustles, life is really what you make it. Building up your brand is whatever you create it. Really ain't no limit. You just gotta love it. Working day and night, it's all about the venture hustle. Hey, venture hustles. Time to take it to the next level. Let's go.
Welcome back to the Venture Hustles podcast. This is Saj, one of the co-hosts of the show. I've got
Jack?
And today we've got a very special guest. We've got Dr. Lyn Yaffe with us, who
Very happy to be here.
Well, thank you for joining us.
Absolutely.
He flew out to be here and to be on the show because we made it very apparent that we were looking to film at our location.
Yes.
So we thank you for participating in that. But Dr. Lyn Yaffe participated in the development of the concept of EPR during the research and development work at the Safar Center of Resuscitation Research, University of Pittsburgh School of Medicine. He's the CEO of EPR Technologies. So we'll be chatting more about that as we discuss.
Absolutely.
And he received his MD degree at the University of Maryland School of Medicine in 1972 and completed pathology and research postgraduate training at Columbia University, New York, with additional molecular biology research experience at the Roche Institute of Molecular Biology in 1978. So just a little,
A lot of a list there of accolades, which is awesome.
I appreciate it. Thank you.
Yeah. Well, welcome. And
My pleasure.
I'm sure it would sound a lot better coming from you.
I went to, I've been involved in some research of various sorts, even from high school, at labs, particularly during the summer. Okay. And then for undergraduate training, I went to Johns Hopkins University. I majored in biophysics. And during undergraduate school, I was always involved in laboratory, maybe an afternoon a week, but certainly on weekends. And then I had early admission to University of Maryland Medical School, went there and was involved in research there as time permitted. And then, as you mentioned, went to Columbia University to major in pathology back in the day and got involved in research there. And was working in research at Columbia, as well as I would cross the river and go to the Roche Institute of Molecular Biology, which was an independent research arm of the Huffman LaRoche Pharmaceutical Company in Nutley, New Jersey. Okay. Now I think that institute has been absorbed into the company, but when I was there years ago, it was independent, and so it was a very interesting research experience. When I was finishing up my residency, or before I finished, to avoid being drafted into Vietnam War without having finished all my training, you could sign up what was called the Berry Plan, which was after a Congressman Berry. Can't remember his first name, or maybe he was a senator. But that you signed and obligated yourself to 4 years in the military, and they would allow you to finish your residency training, then draft you. Okay. So after I signed,
loophole almost.
Right. So after I signed on the dotted line, the Vietnam War fortunately came to an end. So that's enabled me to stay at Columbia and the Roche Institute for 6 years. Normally a residency is 4 years in pathology, but I stayed an extra 2. And then the Navy contacted me because I had obligated myself to Navy service. They contacted me and said, well, Vietnam War's over, but you still signed, you still have to serve your 4 years.
Your term.
So I asked them where I could do research, and they said, well, I can go and talk to the people at the Naval Medical Research Institute in Bethesda, which at the time was across from NIH. So I went there, and they were glad to have me come there. So I started doing research there. The military, they gave you nice amounts of money to do research.
What kind of research?
It was basically in combat casualty care, things in wound healing and sepsis at the time, blood research. So I was involved in the lab there, publishing, doing work, giving military briefs for about 10 years. Wow. And then they said, well, you've been in the lab. We need to have you go to a different station, do something else other than the Naval Medical Research Institute. So they sent me to the Pentagon for a couple of years in the office of the Director of Defense Research and Engineering Medical Division.
Oh, wow,
which
that's
had
pretty
some sort
cool.
of oversight of medical programs. I mean, not any weapons stuff, of course, but it was amusing. You know, if anybody sent a letter to the Department of Defense on a medical issue, you know, usually I was the first one to write the response, and then it went up the chain before it was mailed back. They always were conscientious in answering all letters from the public. And then after a couple of years there, I spent a year at the Bureau of Navy Medicine under the Navy Surgeon General, which is across from the Vietnam Memorial. And then I went back to the lab. And then after that, I spent a few years at what was the Naval Medical Research and Development Command. That was the command that controlled all of the Navy medical research money, just the medical part. And so I was there, and in my final year there, I controlled about $100 million in taxpayer money for Navy labs, universities, and any contracts, all related to Navy medical initiatives.
And how was that experience?
That was a wonderful experience. Wonderful experience. You learned a lot about different programs.
Yeah.
You know, you continue to do a little bit in research yourself, but you got to visit a lot of universities around the country. I got to go to Alaska, I think
awesome.
3 or 4 times, Hawaii a few times, and all over the United States to visit various labs.
Yep.
And then, you know, part of the responsibility was you had to prepare briefings for the Pentagon and even briefings for Capitol Hill. And summaries of what was being done, because Capitol Hill, the offices there's always budgetary oversight of what's being done with the money. So, you know, they want the services to tell them, what do you do with the medical research money? They want to know summaries. So, you know, you'd be involved in preparing that. But in my responsibilities as a program manager controlling money, there was always a big concern in the military about, obviously, those killed in action.
Yeah.
What could be done about those killed in action? Because usually, you know, in Vietnam, 80% of those killed in action die from massive hemorrhage. You know, maybe a certain percentage die from head injuries, which not much can be done about. But those who have massive bleeding, abdominal bleeding, extremity bleeding, if you could get to them fast enough, and
you can save them.
You could possibly save them. You know,
So
they're losing so much blood. CPR doesn't work in a sense.
Right. So this is a perfect segue to
exactly.
you know, we're at Venture Hustles, and I was talking to Dr. Lynn. I was telling him what we focus on, and we're talking about tech, startups, businesses, entrepreneurs, and you know, it's a perfect segue into, you know, science, medical technology, EPR, and why it's saving lives. So you want to tell us what is EPR?
Yes. So in my last few years in the Navy in 1995, I met Dr. Peter Safar at a conference. And I discussed this problem with Peter Safar about saving the lives of those combat casualties who essentially rapidly bleed.
This was 1989, you said?
This was 1995.
95, okay.
And he said, in his opinion, and he had spoken to some people in the Army, the only possibility was rapid, profound hypothermia. That means cooling the body down quickly, because you can't resuscitate them. You can't give them blood. You can't give them IV fluid because they've lost so much blood. You can't do chest compression.
Combat?
This is people who are killed in combat.
Right, like absolute, like ER type situations.
Right,
where
right, like a severe gunshot wound.
Right.
You know, I hate to say it, in elementary school where they bleed so much while the police are waiting to break in that they die. You know, if you could have gotten to them before they were brain dead, maybe you could have cooled them down.
So what's that time difference between, like, what's the in between time?
Yes, if someone goes into cardiac arrest, and there is, because of blood loss, trauma, whatever the cause is, and you're not breathing, within 7 minutes your brain will die. 7 to 10 minutes, maybe even 5 minutes.
Okay.
If you do CPR, which is mouth-to-mouth breathing, chest compressions for circulation. You can keep, if it's done properly, you can keep someone oxygenated and blood circulating if they haven't lost all their blood, you know, for 30 or 40 minutes if it's a group that's trained to do it. Now, Peter Safar, he talked about rapid profound hypothermia. Okay. And he had done a lot of work in mild hypothermia, and he felt rapid profound hypothermia down to 10 degrees centigrade, 50 degrees Fahrenheit, would prevent death of cells.
So what does that exactly mean? Where you're bringing down, like, how are you bringing down the body to that temperature?
Is this a kit? Is this an actual device? How would that work? Okay.
Yes, I'll explain that. Just let me say one thing to credit
absolutely.
rapid profound hypothermia to Dr. Safar. Dr. Safar is considered the father of cardiopulmonary resuscitation. Before Dr. Safar, there was no mouth-to-mouth breathing. There was the rudimentary types of chest compressions. But he showed that mouth-to-mouth works for providing oxygen to the brain with chest compressions. And he and his associates then, they went around the world popularizing cardiopulmonary resuscitation. At that time, there were no paramedics. There was no 911 to call. He started the first paramedics. He trained the first paramedics in Pittsburgh, where he was at the time. And shortly after that, National 911 got started. And it's interesting to note that he took a group of unemployed African Americans in Pittsburgh and a few hospital orderlies, and he trained them to be the first paramedics. Prior to that, white ambulance drivers, because that's all they had, there were no paramedics or EMTs, white ambulance drivers wouldn't go into black neighborhoods. You had to have a friend drive you to the emergency room.
When was this?
This was back in 1959, 1960, 1961. That's how things were. But he trained them. It was called Freedom House. And a few weeks ago, I met two of those paramedics who were in their late 70s, early 80s. But they went on to train other paramedics and become in charge of emergency services in other cities, those two guys. So Dr. Safar talked about EPR. And then it took many years with Army and Navy funding, mostly Army funding, to fund the animal research that showed if you take an animal, pigs, that are permitted under anesthesia, they're bled to the point where they go into cardiac arrest. Okay? They're in cardiac arrest. You wait 5 minutes trying to simulate the arrival of a bystander or paramedics, and those pigs, you start CPR. You know, they do it with a bag. They don't do mouth to mouth, and they'll try chest compressions. Doesn't work because the animal has lost so much blood. Then they do EPR. And they do EPR on the animal by opening the chest, and they stick a large diameter catheter into the descending aorta, just after the arch of the aorta, which is the major arterial system, the aorta that comes off the left ventricle to supply blood to the entire body. So now, they're still doing CPR. They insert the catheter, and now they flush the animal under anesthesia, of course, because it's an animal, with ice-cold saline. And they rapidly cool the brain, heart, and body temperature down of the animal down to, let's say, 10 degrees centigrade. At 10 degrees centigrade, your vital organs don't need oxygen for a few hours. Your heart's not beating. You don't need to breathe.
For a few
you have no
hours?
brainwaves for a few hours.
You're putting the body on pause, kind of.
You're putting the body on pause. And originally, Dr. Safar called it suspended animation, temporary suspended animation. I mean, there's still cellular life. You know, once your cells
freezing.
die, you're not freezing. This has nothing to do with freezing. Water in your cells expands like an ice cube and ruptures cells. So freezing at this point in time doesn't work. There's some things that you can try to replace water with that they can do with just cells. Experiments have been done on some organs, like on kidneys, but it's really not for prime time use yet, Whether you can ever freeze a whole human being and bring them back, that's science fiction. And we're not freezing anyone, and we're not bringing anyone back from the dead.
Cryo chambers.
We're not doing that.
There's rumors about Walt Disney.
Yes, these people are in a temporary, the real term is ischemic, meaning no oxygen, tolerance. So they're tolerant to not having oxygen for a few hours when you're cold. Now, and so the animal is cooled down. Okay, they do the surgical repairs, what they were doing. They give them blood back. Then they put them on an animal cardiopulmonary bypass machine, and they start to rewarm them. The animal's intact now.
Right.
So they have their blood back after they've, flush out the saline that cooled them down. When the animal gets to normal temperature, usually the heart will start spontaneously.
Wow.
If it doesn't start, you can shock them like with a defibrillator.
Right.
Then the heart starts. And in the animal studies, the animals are fine. In fact, they're able to train the pigs to do various things, because pigs are very intelligent animals. I mean, they're not very dexterous, of course, but they can be trained to do things, and they're mentally intact, and when the animals are autopsied, brains look good. It's important to understand that anecdotally, when a healthy skier sometimes, and this has been reported in the medical literature, you may have seen it in the news in past years, that a skier caught in an avalanche is covered in ice, snow, so quickly, and they cool down so rapidly that for that particular skier, when they're rescued after a few hours, there's no heartbeat, they're not breathing. They appear clinically dead, but there's still cellular life. So when they rewarm them by putting them in warm water, a tank, they don't put them on cardiopulmonary bypass to rewarm them the way we do with a trauma victim, but they rewarm them with body wraps. On some occasions, they're able to resuscitate those individuals, and they're normal afterwards.
Wow.
There are also reported cases where people, or particularly small children, fall into a great lake in the middle of winter. They fall through the ice.
Frozen
Takes
lake.
a couple of hours for the divers to find them. Those kids, the surface to body volume is such that they cool down before they hit the bottom of the lake.
Yeah.
And so they need no oxygen for a few hours. Those babies or small children can be rewarmed, and they do fine. They do fine. Whether they've lost a few IQ points, of course, no one knows. But, I mean, they function like normal individuals when they grow up, so they're probably perfectly fine. The difference between a child into a frozen lake or a skier, those are healthy individuals.
Correct.
What we're doing now in the ongoing clinical trial is the worst
Of the worst.
trauma victims that you can imagine. These trauma victims are mostly in automobile accidents or gunshot wounds. And because of the protocols that the FDA wants to see, those individuals are bleeding, but they don't go into cardiac arrest until they get to the trauma center. If they go into cardiac arrest before they get to the trauma center, yes, the paramedics give them CPR or on the helicopter from the tri-state area. They come to Maryland Shock Trauma, which is a premier trauma center led by Dr. Thomas Scalia, who's the chief trauma surgeon. Our clinical trial is headed up by Dr. Sam Tischerman, who's one of Peter Safar's proteges. But our candidates, they have to not go into cardiac arrest until they get to the trauma center. So the trauma surgeons know when time zero is.
Right.
You know, you want to know that the brain has been getting adequate oxygen until they go into cardiac arrest. So they have to go into cardiac arrest after they arrive at the trauma center. Then the trauma team working on them has to be the team that's trained to do EPR. And they can't be on 24/7.
No.
And not every trauma surgeon, has been trained to do this. This is just a clinical trial. So you have to be in the right age group, let's say 18 to 64. You have to have no evidence of head trauma, because we don't have to deal with that.
Yeah.
This is how a clinical trial is done. You have to, meet the criteria to be included in a clinical trial. Like if you're a cancer patient, depending on what they're testing, sometimes every other treatment has failed. And then this new experimental treatment they'll try on you. So it's the same for what we're doing.
So, doctor, I want to clarify, right?
Yeah.
So everybody knows CPR. Like everyone knows what that is,
Mm-hmm.
right? So with EPR, this is not publicly available yet.
No.
Correct? So
No.
this is this still in a trial?
It's still in an ongoing clinical trial.
Okay.
When the ongoing clinical trial, when they've done sufficient cases, the FDA periodically looks and they'll say, oh, we like the results or we don't like the results.
Okay.
They may say, we like the results, but let's expand this to several other trauma centers.
Okay.
You know, that's not still ready for prime time. Oh, and if they say, well, okay, the clinical trial will be expanded. That happens with other clinical trials. Or they may say, well, you know, we'd like you to add this one additional thing to what you're doing,
Right.
maybe to enhance the clinical results in some way.
So they give you feedback.
And they
then
give you feedback, and everything is presented to them. And it's why the FDA, you know, doesn't want the clinical trial data discussed until
It's over.
Until it's over
Yeah.
and it's submitted. You know, when they first put someone into suspended animation, it was reported, you know, in the press, and
Okay.
people get concerned about it.
So are there
concerned
any
about that.
side effects?
Well, from I can say from the animal studies, there are no side effects from the rapid profound hypothermia.
Okay.
Now, in a trauma victim or a heart attack victim, there can be side effects from your trauma. You know, if you have a sudden heart attack because of coronary artery disease or some sort of arrhythmia, whatever the cause may be, if you're lucky enough to have that happen when there's a bystander around and a defibrillator, maybe they'll get you defibrillated.
Right.
And you'll be fine. They'll take you to the hospital, and maybe a week later or sooner you'll be out of the hospital. They'll give you some stents in your coronary vessel so you're good to go. You know, like President Clinton had stents put in. It's fairly common. If the bystander wasn't there and you didn't get CPR, good CPR, soon enough, maybe they still get your heart started, but you're not 100% mentally afterwards because your brain was
brain hasn't-
deprived
yeah,
of
of
oxygen
oxygen.
for a
Yeah.
period of time. But they still get your heart started. So the outcomes from good CPR can be variable. It depends on the timing and how CPR was done and who did it.
Every
and
second
But it
matters.
also
every
like depends
minute,
on the
every
person
minute.
they're doing it to, right? It's
Yes,
like
it depends
their
on
own
their
conditions.
history. It depends
Right.
on their status. You know, if someone has severe trauma and they go into cardiac arrest, and what percentage of those people who get CPR survive?
Yeah.
It's less than 5%.
Okay.
Even if they get you to the hospital, less than 5%. If you have a heart attack for whatever reason, out of a hospital, your chances of surviving are 15%. Depending on the city, maybe 20%. But that's not very good for CPR. If you're in a hospital and you have a heart attack in the hospital, your chances of getting good CPR
Are
and
dramatically
are
high.
40%. But you know, how many people are in the hospital? So it's the same for CPR. It'll be the same for EPR. EPR won't be 100% effective in all cases. It'll depend on the circumstances.
Right.
But if the circumstances are right and it's your loved one or it's you'll want that one extra chance. You want good CPR. That's why everybody should be trained if they're physically capable of administering chest compressions and doing mouth-to-mouth. They should all go to their local Red Cross and learn how to
trained.
do it.
So
Mothers who deliver, they should go and learn CPR if they don't know it in case their kid has sudden infant death.
Yeah.
Everyone should know CPR. So EPR, in my opinion, is eventually going to become a standard of care. That's what we think, based on animal studies. But it's an incremental process.
Right.
First on the worst cases, then
how
trauma
long
center.
has EPR, like when did you found EPR, or how long has it been
Well,
around?
EPR was founded a number of years, actually, 2006, but we really haven't done anything since about mid 2019 or early when the FDA said, okay, we're going to let this clinical trial begin. And so then the company said, okay, well, we've got something to talk about now. We can do something.
When did you apply to the FDA? When was that? That was 2006?
No. That must have been 2017, 2018.
Right, I read 2016 or 17 somewhere.
Yeah, it could have been 2017.
And so it took
a while for the FDA. Right.
Got it. So my question was, when you're in that test phase, right? We're talking about the early years, 2006, 7, 8, 10, 12. Do you have to get some sort of approval or while you're doing these animal studies?
Oh, yeah. Oh, absolutely.
Okay.
Oh, yes.
What does that look like?
All animal studies must be approved by the NIH authorities. Okay. And every laboratory in the U.S. has an animal review group, just like they have for humans, a clinical group. In other words, if you're going to do a clinical trial at university, like at Columbia, Medical Center or wherever, that clinical trial has to pass approval at the local level as well as the FDA level. There are a lot of steps. And if you're doing research in animals, whether it's a mouse, a rat, or a pig, or whatever animal you're using, it has to be approved by the local animal review committee, animal oversight committee, and then it has to go to the next level. Usually it's the funding organization. So let's say in our case for early EPR studies, when pigs were being done and they've done rats, the local lab reviews that. Then it has to go up to the Army Animal Use Authority, because the Army that's funding it is ultimately responsible.
Got it.
Right. They have to give their approval.
So their departments, depends on where you apply, you have to follow those procedures.
You have to follow all those are national procedures.
Got it.
For all,
yeah, I mean, to a lot of the people and a lot of the listeners, a lot of this is new information, right? They wouldn't know. So I want to break this down because we've talked about a lot of things, but the main particular technology that you played a role in developing and researching, right? I want to understand from a technology perspective, how does the mechanism work, right? Because let's use an animal as an example, right? How big is this device?
Well, we're talking about several device applications.
Okay.
What you need is an appropriate catheter kit.
Okay.
And you need different catheters, which right now, let's say, are proprietary, and will be submitting the patents soon. It takes a lot of money to submit patents.
Right. Yeah.
But you need a catheter kit for gaining appropriate vascular access.
Okay.
To get into your arterial system.
So you have to go into the heart and place. This is what I want to understand the flow.
Yes.
Right. You have to
right now it goes into the upper descending aorta, because in the human situation, as was, let's say, the way it was done in the animal as well. At a trauma center, when they are ready to give up on CPR, they will do a left thoracotomy. They cut in, open the left chest, spread the ribs, and with a gloved hand, they will manually massage the heart.
And this is done now?
This is done now at a trauma center.
Okay.
Right.
Okay.
As the last effort.
That was one of my questions, where with this, I mean, you're going in.
You're going in.
You're going in here.
Now, this is
so for the clinical trial, you're already in.
Yeah.
Even if you're not lucky enough, in a sense, to get EPR, because the trained team is not on to do it, they're probably going in. They evaluate the situation. If good CPR was done, they want to try this for 30, 40 minutes. If you're a young person, if you're 85 and you suffered CPR, a heart attack CPR, maybe they're not going to do that.
Pardon me if you've already said this before, but this is going to be done. So CPR is right now done by
paramedics, bystanders.
Correct. So this mechanism or multiple devices that comprises EPR. This would be needed to be carried by the paramedics.
Ultimately, yes.
Okay.
First, obviously, the FDA is going to say, okay. Then they'll say, well, let's expand this to other trauma centers. That could be a next step. Then they might say, well, let's do this at emergency rooms too.
Right.
Okay. And let this be a technique on the wards What if someone goes into cardiac arrest? You're on, 3B.
Right.
Let's have a team able to do it there throughout the hospital. It takes mobile equipment, and it takes certification to do
There's
it.
not a lot of room to carry with the paramedics, and it's also like that's why I was curious to understand.
It would be a mobile device. In other words, the appropriate, friendly, and I'll say semi-automated catheter placement devices, because we'd want to make it not only easy for a trauma surgeon, but even easier for a paramedic. Those don't take a lot of space, okay? As far as ice-cold saline for the cool-down, you can have at the ambulance bay, 20 liters of solution that is in cold, ready to go, 2 degrees centigrade, ice cold, and on a large paramedic unit, they have power, so they can have a refrigerator on it.
So the mechanism basically is, so if obviously the ambulance and the paramedics would be the last step, and that would require specialized training, because you're going and doing something on the fly. Could literally be in the middle of the street. You're ripping someone's open, and then doing the catheter through the aorta.
Right. There are other vascular accesses that a paramedic could use that don't require a left thoracotomy. Okay. In a trauma center, and all of that would have to be studied and approved appropriately for paramedics. At a trauma center, of course, they do a left thoracotomy routinely, in the appropriate case, particularly in a case that might end up getting EPR. So the heart's right in front of them. So the aorta is right there. Usually in these cases in a trauma center, they've opened the chest. They're massaging the heart. They make a decision about EPR if everything else lines up. They will put in a large bore catheter into the arch of the aorta, where the aorta comes up from the left ventricle, goes down. Descending aorta, abdominal aorta. Just where the arch turns, they'll put in a large bore catheter, and they put what's called a purse string suture around that, so they inject saline. It doesn't leak out where they put the catheter through. At the same time, they'll put a clamp on the abdominal aorta, so all of the cold saline is shunted to the brain and the carotid vessels. It also
is where
goes
it needs to be.
Where it needs to go. It goes to the heart because your coronary vessels come off the arch of the aorta, and it goes to your upper arms, which also come off. And after the brain reaches target temperature, which they determine by tympanic membrane thermistors, which is an elegant thermometer.
You're saying a lot of big words, doctor.
Then they release that clamp.
So this is exactly why I'm trying to reel this to like a more simpler version, so it's easier to understand. That's all very technical. But just to understand, the procedure is, let's say at a trauma center, a lot more doable, right? Because they've already got you set up, and then let's say that EPR is an option. So that's let's just say it's a tube, right? Would that be safe to say?
A tube is a catheter.
Catheter going into the aorta, right? And this saline that's basically resting at 2 degrees, but the purpose of it would be to get your body or your brain temperature to 10 degrees.
Your brain first.
Your brain first. So 10 degrees is what the target was.
Yes.
Which is basically putting you in a suspended animation. Let's say,
and they do that ultimately to your whole body.
Right, ultimately to your whole body. What does this allow you to do? So what this allows to what you mentioned earlier was, now once your body's in a suspended animation, now it gives you what, 40 to 50 minutes? Is that what you said?
Up to 3 hours.
Up to 3 hours.
Up to 3 hours.
That's a long time.
And during that 3 hours, you don't have to worry about the brain, so to speak. You don't have to worry about giving it oxygen. That's what the clinical trial is about.
Yeah.
That now at Maryland Shock Trauma, where the trauma surgeons have been working on them in one bay, they move them next door now for definitive surgery. So maybe they were having abdominal bleeding.
Yep.
Maybe they had some severe leg injury, even though they put a tourniquet. They were still losing a lot of blood abdominally or whatever. They patch all that up. They do the necessary survival surgery.
So, Mike, I guess compared to that, let's say 3 hours is a long time, right? It gives you a lot more options now on how do we operate, how do we move to the next phase. What is the current time now? So you said 7 minutes from someone going into cardiac arrest to being brain dead.
The brain, right? If you don't get oxygen to your brain for 7 minutes, you're in dire straits.
And if you do effective CPR, it could be 30, 40 minutes.
It could go 30, 40 minutes as long as you
30
keep
minutes
oxygen.
to 3 hours, I mean, it's a pretty big jump. It's a good jump.
Well, during that 30 minutes of CPR, they still can't get your heart started.
Yeah.
You know, we're assuming they can't get your heart started
Right.
before EPR even comes into play. So, you know, ultimately, you know, if the dedication and the dream for EPR becomes a reality, maybe at a trauma center they won't work on you for 30 minutes. They'll say, let's go with EPR. Let's cool that brain down as fast as possible. Or maybe they'll cool your brain down to a certain temperature and continue you know, to do some surgical things.
So,
you know, to get ready for
Whatever
other
may
items.
follow.
You know, when I say limited cool down, what I'm referring to is that in difficult neurovascular surgery, they'll put you on cardiopulmonary bypass, which is like a heart-lung machine.
Yeah.
And they'll lower your temperature down to, let's say, 16 to 20 degrees centigrade, so they can lower your blood pressure and help to protect the brain while they're doing difficult neurovascular surgical surgery on your brain. So that's sort of deep hypothermia, which is above profound where we are. You know, there's ultra profound, which it's hard to get to. We go to profound, which is, let's say, 5 to 15 degrees centigrade. Then there's deep, which is, let's say, 15 to 25. Then there's moderate. Then there's mild. Mild hypothermia is just a few degrees below normal, so your heart continues to beat.
Okay.
If you go below mild, your heart will stop beating. So if you go into moderate or deep, you need to be on cardiopulmonary bypass so that blood keeps circulating that's oxygenated. Otherwise, you'd need CPR, which is not done in that. Mild hypothermia is used now at all the major hospital centers and regional centers. If you have a heart attack and you need CPR and they get your heart started, but you remain unconscious because it was a severe heart attack and maybe, you know, for whatever reasons you're still unconscious,
Yeah.
they will do mild hypothermia. So they'll lower your body temperature with external cooling wraps usually, and that takes the edge off of, it helps to protect the brain and recovery. Has been discovered in clinical trials. So that's considered the standard of care now, FDA approved, American Heart Associations. That's mild hypothermia. Completely different use, different procedures than rapid profound. It all comes under what's called therapeutic temperature management. It's all different degrees of hypothermia, but they're different procedures for different purposes.
So Dr. Lynn, how effective, and I'm assuming countless different trials have been done on animals, right? How effective are they? Like, if you had to put a percentage, how effective is this procedure within the animals based on this, I guess, let's say, hypotheses, right?
Extremely effective. I don't want to say 100% because if you do enough animals, you're always, you know, pushing the envelope.
Right.
But
So would you say 90%?
If you do EPR in an animal that's been exsanguinated, that's bled out, and you do good CPR on the animal from the time they go into cardiac arrest, good delivery of oxygen, good chest compressions, and then when you can't get their heart started, even though you've been doing good CPR, and you do immediate EPR and rapidly lower their temperature, and do that for up to 3 hours, the animals are wonderful. I would say close to 100% come back. When we would push the envelope and try to do it at a slightly higher temperature than target temperature for 5 hours, well, then the animals don't fully recover. You may get them back, but maybe they have some neurological deficits. So it's all about
the preparation.
It's all about the quality of CPR. How long are they without oxygen when you're working on them? How good was CPR? How long it took for the cool down, and how long they were then in EPR before you put them on bypass to do rewarming and resuscitation. So all of those things become important. The ideal conditions, the animals all recovered. It's when we would push the envelope. Instead of doing this, let's say at 10 degrees centigrade, can we do it at 15 degrees centigrade? Because you can always get to 15 faster than you can get to 10 to protect the brain. So, I don't want to go, I could, but I don't want to bore you with the experimental details about what neuroprotectants we added and what things you could be done, because that didn't drive to the FDA, let's test one variable, which is cooling.
I have a question for you. What is it like being like the chairman or CEO of a company like this? What is it like?
Well, it's fascinating.
Okay.
I feel privileged. Well, I feel privileged to have worked with Dr. Peter Safar. He was a very great man. He was nominated for the Nobel Prize several times. And Peter Safar, the father of CPR, you could say he's responsible for saving, I don't know, hundreds of thousands of lives over the years since the 1960s. So, I feel dedicated to his memory, and our entire team, which is a small number of people right now, and the people at the Safar Center, the people at Maryland Shock Trauma, who are all, let's say, proteges and work with Dr. Safar. They're very dedicated to maintaining
his legacy
EPR, his legacy. For years, they've had at the Safar Center, each year they have the Safar Symposium, the guest Safar lecturer. They have a Safar dinner, and then they have the next day they have a session on medical simulation, which is also, in a sense, in memory of Dr. Safar, who was the head of the first Department of Anesthesiology at Pittsburgh. In those late 50s and early 60s, anesthesiologists worked in the Department of Surgery. It seems funny now, but he started the first independent Department of Anesthesiology at Pittsburgh, and the second head of anesthesiology was a guy by the name of Winter. And so the medical simulation department at Pittsburgh is named after Winter. But, the first simulation mannequin, Resuscitation, Dr. Safar had made for people to practice CPR now. That's models of that are still used. Now they have, almost artificially intelligent simulators, full size. But the first medical simulator was Resuscitation. If you go to Google and type in Resuscitation, you'll find it. There's a whole lot of information.
That's super fascinating. I mean, it's crazy. How many years would you say you've worked with Dr. Safar?
From 1995 to his death in 2003.
Okay.
Wow. So about 8 years.
Yeah.
Yeah. And, he started mouth to mouth, wrote the book, The ABCs of Emergency Medicine, meaning A for airway, B for breathing, C for circulation or chest compressions. He trained the first paramedics. The first paramedic ambulance he designed.
That's awesome.
Freedom House. A Hollywood documentary was done about Freedom House.
Oh, wow.
It's not on Netflix, but I've seen it at Pittsburgh. And more recently, the University of Pittsburgh, the Medical Center, has started Freedom House 2. And they've taken a group of minority individuals, men and women, different minority groups, who haven't really completed their education. They make sure they get their high school degree, and they give them intensive training, and many make it through to become paramedics. Some don't get full certification. They can do, they can become other things in the emergency field, whether it's receptionists or 911 or things, but they call it Freedom House 2, and that's where I met these two early paramedics, because they were there speaking about their early experiences with Dr. Safar.
I mean, I think this is pretty cool. They should do a documentary on your entire experience over the last like couple years.
Well,
You
it
know?
is fascinating. Maybe one day they will, but
No.
there's a lot. If you go to the YouTube and type in EPR or suspended animation or my name or Peter Safar, there's a lot that comes up. And then on our Start Engine crowdfunding site, which is right now scheduled to end in 2 weeks, though we may be permitted to extend it. I have to see. There are all these SEC rules to follow.
Yeah.
But if you go at the end of that lengthy page, it explains everything about EPR. There's a lot of videos and, all the risks. We've had about 93 investors you can read about.
Wow.
The terms and everything there for our last
congratulations
2
with
weeks.
that.
But there's a lot of video there I've put about, you can see Dr. Safar doing the first experiments in mouth-to-mouth. And you can see a lot about Resuscitation and a lot about Freedom House. And the difficulties they had because it was an all African American group.
I mean, this is super fascinating to me personally because
Historically, it's fascinating.
like just the whole like concept of EPR, CPR, and just everything that
I mean,
that
the tech
you
is
brought
like
to the table.
super cool.
Like I have
honestly.
a family member. I mentioned this to you before. So one of my family members, his name is Marjan Mujib. I don't know if you know who he is, but he's a cardiologist in Penn Medicine, Lancaster, Pennsylvania. And he's done a lot of like research work, and this is definitely his realm. And I'm curious to see if he's aware of any of this, or even Dr. Safar. It's pretty interesting.
There may be some who are aware. A lot of trauma surgeons are aware of this. In the early days, when I controlled the early money for this, before I got out of the Navy and got permission from the Navy to continue working with Dr. Safar to make sure there was no conflict of interest. Some of the research that were funded, collaborated with the Safar Center, and they are, of course, aware of this. And because of Sam Tischerman, who's doing the clinical trial, he's given some talks at trauma meetings, and Dr. Tom Scalia, who's a preeminent trauma surgeon in the U.S. and the world, really, he's a strong proponent of this. Before the clinical trial got started, when we were talking with the military about funding and how much money, we had 7 or 8 trauma centers that wanted to participate because trauma surgeons know when they give up on CPR, on a loved one or a young person or a gunshot victim or a automobile accident, that's it. There's nothing more for them to offer.
Yeah.
That's why they all love the idea of EPR. And that's why I think whether EPR Technologies, and hopefully I'm confident will be successful, I mean, there are always risks, but it's inevitable. Just like every other medical advance, it's inevitable. It will happen. Just like it's inevitable that what they're doing in cancer in the last 2 years is just phenomenal. What they're doing with vaccines now because of COVID with messenger RNA, which was originally introduced for vaccines against tumors, and they switched to COVID, even though they're still doing tumor work, is inevitable. And what's being done in anti-aging is also phenomenal, what they're discovering about anti-aging.
What do you think about Elon Musk's Neuralink?
I really don't know a lot of details about it, but I do believe that one day they will have a bed of human neurons, cells from a brain that are growing on, let's say, in a petri dish on a plate, that will have activity. And in some way, somehow, those cells will eventually have some sort of cortical activity that will plug into some sort of silicon grid.
On a petri dish?
On a petri dish or in some artificial organ.
The way
a petri dish may be, I'm trying to make it
I'm literally
simple,
picturing a petri
that's
dish.
kind of, I'm on the same page as you.
You know that they're making
Clones?
artificial organs.
Okay.
In other words, 3D printing. You may have seen in the news, they recently printed, they took cells from a lady, her own cells, and grew them up, and they 3D printed an
So
ear.
insane.
She was
Yeah.
born without an ear, and they attached it. It won't be rejected. There have been, they've been 3D printing pieces of liver, pieces of kidney, arterial
Yeah, the
systems,
3D
bladder.
printing world is
So they'll, at the same time they're going to 3D print organs, they're also conquering rejection. So
Yeah,
maybe
yeah.
they'll use humanized pig organs. They're following all of these. So why not some sort of 3D printed neurons that formulated the right way from neural stem cells, they form a primitive brain perhaps that starts to link up with itself. I know it sounds like science fiction. I'm not predicting this for tomorrow, but I think it's inevitable that it'll happen. And maybe that will be planted into, I don't know.
Yeah, I mean, what
You
Elon
never
Musk
know.
was saying was, he
I
was
mean, there's
gonna
work
plant
being
stuff
done
in
on
people's-
these
yeah.
on these
Oh, yeah.
concepts.
Yeah.
Oh yeah.
You
I
know,
mean,
it's far
there's
out there.
active work, demos. I mean, there's so much that's out there.
Yeah.
But
We're
you
not
know,
going to download ourselves into anything quite yet.
no,
Not
I think
yet.
that's
no.
too far on the
Like
horizon.
Yeah,
upload
yeah.
our conscience conscience
no.
into
Not
something,
yet.
a suspended state maybe, and then re-download into another
Well,
body.
is it possible?
There's a
to-
movie like that.
Is it possible to be in suspended animations for decades and decades?
Right.
Not frozen, unless they're able to replace the water in every cell. Is it more likely that you could be in a prolonged state of suspended animation or hibernation? I think that's more likely than being brought back from a frozen state. You just have to be able, in that suspended animation, your cells probably still need some oxygen. They need some protectants. Maybe that will be possible one day.
I mean, as technology evolves, you never know what's like. You can
Exactly.
never rule any of this out, right? I mean, think about where we
Yeah.
were 10, 20 years ago.
5.
5 years ago.
Yeah.
It's
I
kind
mean,
of insane.
What Elon Musk does is truly fascinating.
Yeah.
And many of the things that he's doing, whether you're talking about electric vehicles, those go back decades and decades before he was born. The idea of electric vehicles, the tunnel borers to make tunnels, that's science fiction from decades
the
ago.
hyperloops. See, the
hyperloops, and
hyperloops are,
even brain downloading to a brain, that's
Well,
science fiction too.
the
So
hyperloops-
he's pursuing this. They weren't original ideas of his,
no.
but it's still wonderful what he's doing.
I don't think he's ever publicly, claimed
No,
them to
he
be
hasn't. No, I'm
Yeah.
not. I
original.
don't mean it in any critical
No,
way.
no,
I'm just saying these are fabulous ideas.
100%.
And he's
because-
actually executing
because
it
of
on
his energy and capabilities.
Like
He's able. The technology is available for him to execute on.
Yeah.
With Hyperloop in Japan, I don't know, the bullet train, I think is it in Japan?
Yes.
It probably is. I mean, that existed for so long. I mean, the speed, right? It's
Yeah.
not the same technology as the Hyperloop. Hyperloop's a variation of it,
Yeah.
with the chamber, closed chamber, pressurized chamber. But I mean, different variations of that same technology exist.
Yes.
It was. I don't even think Tesla is like the first electric car, right? It's just like the first mass production.
Mass production.
Like there's been so many different variations.
Yes,
He's
Now,
just
there's
perfected
there's
it.
there's supposedly a three-wheeled electric vehicle called I think it's Optera. That if you get
Aptera, I know what you're
that
talking
if
about.
you get all of the battery packs, it has a range of 1,000 miles.
Yeah, it's insane. It looks like a tricycle.
A tricycle?
and like a trike.
It's
sorry.
3 wheels.
Yeah, it's three
but it's
wheels.
covered. You have two-seater
It's a
for
it's
people.
a coupe 3-wheeled
Okay.
car.
I know what you're
for
talking about.
1,000 miles.
That has solar powered capabilities for it to charge when through solar panels.
Yes.
And the range is insane. And what's crazy, I watched a video on this recently. I think it was like $20,000, like entry level $25,000 to get that car.
The important thing we can do is anti-aging. Because I want to go for another 50 years. I think all these things become real.
I think you find the secret, you let us know as well. We can stay ahead of the curve.
Absolutely.
Doctor, if there is anyone listening here that wants to get into this kind of work, how would you suggest that they start?
You mean work in rapid profound hypothermia or
No.
medical tech?
I guess, yeah, I should ask a better question. More so the field of like research with the medical field
Well,
and
obviously,
kind of.
if you're interested in medical research, you've got to get a PhD or an MD or both.
Okay.
I guess you could also be involved in research by becoming a lab technician.
Okay.
You can do very well as a lab technician. I think they're well paid. Obviously, you can get your bachelor's and master's a degree for a lab technician. Excellent field to be in.
Yeah.
You need more and more of them. if I have any piece of advice for any startup company, for anyone who wants to be an entrepreneur, understand what you don't know. You know, like I may know the science.
Right.
You know, I work with people who know the science even better than I do. But I also work with people who I've started to work with about raising money.
The business side,
I now know what a fractional CFO is. I knew what a CFO was. I didn't know what a fractional was.
Yeah.
I now know much more about podcasts and social media and the importance of that. I never really knew much about crowdfunding, but I'm working with people now, and more people are aware of EPR, and so it just helps promote. And we'll get to our goal ultimately.
I think you put it perfectly. You got to be persistent
and work with experts.
And you're doing a great job. You're surrounding yourself with people that are experts at things that you're not, and you're being able to translate what you're trying to do in all kinds of mediums. Thank you so much for coming in, Dr. Lynn.
Oh, it's been my pleasure. Very much talking to both of you. I enjoyed it very much.
This is a super change of pace for us and our audience in terms of information, the richness of info that you brought in. Where can people?
Okay. I was just going to say what you're going to ask. If you're interested, while we have 14 days remaining, assuming we may or may not be extended, if you go to www.startengine1word.com/EPR-Technologies.
Okay.
The hyphen. You'll see us, or if you go to www.epr-technologies.com, it'll also tell you where to go.
So we'll obviously put all the links in the episode when this goes live, and both in the audio and the video, of course.
No problem.
And anything else? You got any Instagram, TikTok accounts you want to shout out?
Yes. Okay. Well, I don't know them by heart, but if you go to our website, at the bottom of the page, there's Instagram, Twitter, Facebook. If you go to the Start Engine page, there's my own personal LinkedIn, and EPR has LinkedIn. We have someone who takes care of this.
Absolutely.
Because I already get, if someone wants to email me about this, and my email is out there, it's my first initial, Lyn, L Yaffe, YAFFE, LYAFFE, at EPR-Technologies.com.
Awesome.
Email me and, do your best to make a question about EPR. Don't make it seem like it's some scam. And give me a few days to answer it, because I've got a lot of these kinds of emails coming in. I try to respond to everybody.
You do. You and your team do a
awesome.
Fantastic job. Our coordination with you has been pretty smooth and effortless.
And we'll put your podcast up on all of our.
We appreciate that.
100%. On all of our links.
Well. You wanna?
Yeah. Well, again, I guess Doc, it's been a real pleasure. I appreciate it absolutely. And as always,
thank you very much.
For all of our listeners, we hope you guys. Well, I'm sure you guys learned quite a bit about EPR, Doctor. We appreciate you sharing. As always, you can find us on YouTube, Spotify, Google Podcasts, Apple Podcasts, and really anywhere else that has podcast links. So we appreciate you guys as always, and. Hope you guys enjoy the day or night wherever you may be located. So
we'll see you next time.
Thank you.
Absolutely.
Venture hustles. This is venture hustles. Turn nothing to something. Start a business. Get it jumping. Ay, told myself that I would make it, and I'm never quitting. Staying motivated, and I started with a vision. Yeah.